So we're back. Welcome to episode 45 of the MedEdit podcast, your ultimate resource for evidence-based medical education.
This is the podcast where the listeners decide what medical topics we cover.
Today's episode is all about boobs. You heard me right. Breast cancer screening can be very scary and anxiety-inducing for many women. You don't want to be told it's abnormal. You've been told it hurts to have one. Well, we want to talk about the best options out there for breast cancer screening and hopefully ease your mind when it comes time to actually get screened.
We have a wonderful guest on today who's going to help us walk through all of these options. And we are so excited to welcome Dr. Robyn Roth. She is a fabulous breast radiologist who is also known as @theboobydocs on Instagram and the host of the Girlfriend's Guide to Breast Cancer podcast.
We have a lot to cover, so let's get started.
We're your hosts, Dr. Carrie Sorrell
and Dr. Jessica Gray. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
All right. Well, as I already mentioned, Dr. Robyn Roth is a rock star who has an amazing Instagram page. I love it. It's so good. An amazing podcast that I already mentioned, but she is an associate professor of radiology specializing in breast and abdominal imaging. So she knows what she's talking about, guys. Okay. Runs a very popular breast health social media platform where she discusses breast cancer in a very fun and educational way, which we love. She's passionate about busting misinformation and helping people understand ways to find their breast cancer early. She hosts a great podcast, The Girlfriend's Guide to Breast Cancer, like we mentioned, to help navigate a breast cancer diagnosis and supporting a loved one. She also hosts a wonderful annual fundraiser, the Booby Bash, which will be held Saturday, October 18th this year in Cherry Hill, New Jersey. She has a great sense of humor, which you have to when you talk about things like boobs, who guides women through their breast cancer screening options on social media. Welcome to the podcast, Dr. Roth.
Thank you so much. I'm so happy to be here. And this is such an important topic that I'm glad we're covering.
It's always so fun when you meet somebody who has such the passion for education in such a way that we always talk about trying to meet people where they are, right? People are getting all their education, a lot of their education on social media these days, and you are fighting that battle up front. You're addressing all those myths, which we're going to tackle several of them today. So
I think that's the most important thing is that we need more doctors on social media that are providing evidence-based medicine, because the internet is such a scary place and you don't know who to believe. And I feel like there's so much misinformation swirling about breast cancer screening, and it has the potential to be very dangerous. So my whole platform is built on, busting those myths and really giving women the information that they really need to save their lives and find their breast cancer early.
And for those who are just listening right now, Dr. Roth is also wearing an adorable little Cherry's Boobies shirt. It's just so cute. So she gets it. We play with the idea about talking about breast health, but it is fun. And there's all sorts of cute little hashtags and things to go with it. But it is really important. We're talking about cancer here. With almost 300,000 new cases of invasive cancer in women in the United States a year, breast cancer screening is a really important topic, and it's an evolving field, right? And so most people are just familiar with one subset, maybe one type of mammography, but there's so many different aspects to it. And that's where Dr. Roth is going to help us. And I think the other thing a lot of people think is, I don't need to worry about that until I'm old, right? Yeah. And so that's definitely not the case. We'll touch base on that too. So Dr. Roth, just start us off. Who, where, what, start with
all the whys.
Whys, yes.
As you mentioned, breast cancer is the most common cancer worldwide in women. And the goal of breast cancer screening is to catch it before it's palpable and while it's very treatable. Because with early detection, I like to say early detection is the breast protection, because when we find your breast cancer at the earliest stage, we have a greater than 95% survival rate. And these are the numbers that we love to hear. So when we're talking about breast cancer screening, I want to start off this conversation by saying that most people who are diagnosed with breast cancer have no known family history and no known genetic mutation. Actually, the two most common risk factors for developing breast cancer are being female and getting older. So by definition, I know, wah-wah, right? That's all of us. So by definition, we are all at risk, some more than others. And that's where the conversation needs to start, is that, breast cancer screening recommendations are really based on your risk factors. So we really want to emphasize people understanding their breast cancer risk at an early age. So one of the newer recommendations says that all women, especially Ashkenazi Jewish and Black women, should find out their breast cancer risk using an online calculator, which we can link in the show notes, the Tyrer-Cuzick calculator. I like to direct them to, but find out your breast cancer risk at age 25 to 30. Because if you are at high risk for developing breast cancer, based on the calculator greater than 20%, we would start breast cancer screening earlier and more often. So we're all familiar with the recommendation of getting an annual screening mammogram every year, beginning at age 40. That actually only applies for average risk individuals. So that implies that you understand your breast cancer risk, and most people don't. So that's why it's so important to have these conversations. Olivia Munn has been really helpful in spreading awareness of the online calculator. Because if you are at high risk for developing breast cancer, greater than 20% lifetime risk, then we would start breast cancer screening as early as age 25 with an MRI. And then at age 30, we would add on a mammogram in addition to that, and kind of alternating every 6 months. So, by 40, you're way late if you are elevated risk for breast cancer. When we talk about breast cancer risk, there are modifiable and non-modifiable risk factors, which you can get into. But the big red flags would be breast cancer in a first or second degree relative, especially if it's premenopausal. Also known genetic mutations in the family, or a prior biopsy that was high risk in the breast. So that's a great place to start. A good rule of thumb is to start breast cancer screening 10 years before a first degree relative that was diagnosed with breast cancer, but not before the ages I stated. So if your mom was diagnosed with breast cancer at age 35, you would start MRI at age 25, and then add on a mammogram at age 30, alternating every 6 months.
So I definitely think that that's, especially in primary care, we talk about this all day long, every day. But for every one of my patients, even if they feel perfectly healthy, that's a minimum conversation we have, starting at their annual wellness, that once a year preventative visit. But I'm going to take a moment to throw in here because I learned something prepping for this podcast interview this week. Carrie actually texted me and she's like, hey, can you calculate your Tyrer-Cuzick score again for your breast cancer risk? And I was like, oh yeah, I did that a couple years back. I think I did that about 7 or 8 years ago when I kind of came out being an attending. And then I did, because I have not very much at that time, breast cancer risk in the family. And so I calculated my score and it was like average risk, no big deal. I even got the genetic testing done for some of the other cancer stuff, all normal. So I was like, not going to worry about that ever again. That's not the highest on my list. Well, more interestingly, I've had a couple family history things pop up in an aunt, and my mom was diagnosed with breast cancer. And so I just kind of thought, well, she was over the age of 60. I didn't have to really think about it as much as one of the, as she liked to call it, the old lady breast cancer. And so again, I didn't think anything. So then Carrie texts me the other night and I have to calculate my breast risk score. And all of a sudden my score is in the high risk category. And I was like, wait a minute, we're starting this process again. And so now I'm doing the mammograms and the MRIs. And so it was just so enlightening, even as a physician, to be like, hey, when you do have that new family history, we have to update that score as well. And I feel like even as physicians, that part might get a little lost because I forgot it for my own self.
That is so important, is that your breast cancer risk changes as, more information comes to light. So your family history, if you get a mammogram and you find out that you have dense breast tissue, that's a risk factor. Things like that. Biopsies prior, even if it was a benign biopsy, it can still increase your risk of developing breast cancer. So all that goes into play. So it should be an ongoing conversation about your breast cancer risk as more information comes to light. So very important.
And I think
very important point.
Kind of misconceptions people have is what screening means. Like what they like, well, okay, screening, like they think just mammogram. That's all they're familiar with. So what are some of these recommended modalities, starting from what you can do at home yourself to some of the more common screening tools we are using?
Yes. Okay. So I'm so glad we're talking about this. So, I want to also point out that we are seeing a rise in young breast cancer. And so a lot of patients that are being diagnosed are not even at the screening age. And that's a problem, right? Because really over 80% of young women who are diagnosed with breast cancer find their own breast cancer abnormality themselves. Okay. So I am a really strong proponent of a monthly self-breast exam. I think most breast cancer experts are. And I think this is where it gets confusing and political from the American Cancer Society technically not recommending a self-breast exam. But if we're not going to teach a self-breast exam, how are young women who are not being screened regularly for breast cancer able to find their own breast cancer? We have to empower them and give them the tools. So which is why every month on the first of the month, feel it on the first, I teach women how to do a monthly self-breast exam, because I do think it's so important. When you find a lump, most likely it's nothing, but you pay attention to it over the next few days and see if it's getting bigger, harder. We just don't want to, I think that a lot of young women specifically are gaslit and told it's nothing, it's just a clogged duct, you're too young for breast cancer, when we know that's not the case. So I think having a conversation, giving patients the tools to understand that what their breasts normally look and feel like every month is really important, because often they're going to recognize a change. And then I would say that screening is for asymptomatic individuals. Okay, so once these women come in, they're not screening, they're diagnostic now.
Right.
That's an important distinction. So, when we talk about breast cancer screening, we talk about the mammogram as a staple, gold standard for breast cancer screening on the general public population on a cost-effective scale. This is not to say it's the best breast cancer screening test we have. If we could do contrast-enhanced MRIs on everybody without, any thought, then that might be more sensitive and specific, but that's not the case, right? You have to screen an asymptomatic population. You have to have some test to some kind of a widely available test that's cheap, minimal side effects, and that can screen a large population without doing as much damage and costing an arm and a leg. So we start with a mammogram. And then when we have dense breast tissue, we know that mammograms are not as effective in women with dense breast tissue. So you could find out if you have dense breast tissue by reading your mammogram report. Also, you'll get a letter in the mail saying that if you have dense breast tissue, that it can make it harder to find small breast cancers on a mammogram alone. It also increases your risk for developing breast cancer. It's an independent risk factor for developing breast cancer. Because of that, if you have dense breast tissue, you might want to consider adding an ultrasound or an MRI, depending on your risk factors. So typically, the patients that are average or intermediate risk that have dense breast tissue will get an ultrasound, and patients that are high risk get MRIs. Now, there are more cost-effective ways to do this. Like they have abbreviated MRIs for someone who might be average risk but wants that extra layer of, screening, because MRI is better than an ultrasound based on sensitivity and specificity. So, start with a mammogram, go into ultrasound and MRI if you have dense breast tissue, and if you have risk factors, is a great way to start thinking about it. And that monthly self breast exam where we're going to catch anything that the mammogram didn't pick up or that we weren't looking for because we weren't screening you.
Yeah, I think that's such an important point, because I have the same battle as a gastroenterologist with colon cancer rates, because we keep seeing all these things about rising in young people. It's because we lowered the screening, realizing that we weren't catching the people that we need to catch. And when I was in training, very much so is, oh, you're too young, you come in with symptoms, but you're too young for it. And it's had to change the way I practice medicine, because I'm like, well, really nobody's too young anymore. Like, it's kind of, I don't care if you're 29 or 35 or whatever, it's kind of shown us that it's happening at a younger age, and we kind of have to change the way we approach these patients instead of just saying, oh, well, you're too young for these things anymore.
Absolutely. We have to take the patient's complaints seriously, independent of age, because we really I think the data is always lagging behind, but I'd say the most of my patients that I'm seeing in my clinic, in my breast clinic, are late 20s, early 30s with diagnosed with breast cancer. It's scary.
It's very scary. Yeah.
That is scary. And I think that even in my clinic too, same thing. Like a young woman comes in, I'm even as a physician, I'm ordering that ultrasound. I'm ordering the mammogram. I'm ordering that extra step. I'm not even ever anymore assuming, oh, it's just a fibroadenoma. I mean, I feel like that's what we were taught originally. And there's no way I'm even the liability and the risk, because the numbers are just too high. It's just like when they come in with the bright red blood in the stool and all this stuff. We're like, oh, you're going to go see GI. I'm not assuming anything's hemorrhoids anymore. We're going to make sure that we get everything worked up the way it should, which is what we want to do at this point. It's just it's sad that the cancer rates have led us to need to do this.
Yeah,
so
absolutely.
We all know how important mammograms are for breast cancer screening, and there's been a massive amount of misinformation on the internet. I mean, I just had a patient this morning who was telling me about how she does not want to get a mammogram because she's afraid that they're going to cause breast cancer due to radiation. Can you please tell us a little bit more? I know this is a passion subject for you to talk about. And then also, they're always saying, well, I'm not going to get it because it hurts horribly. It's the worst pain I could ever experience. Just tell us a little bit more about that.
It's a hard time being a breast radiologist on social media because there is so much misinformation about mammograms. And honestly, it's kind of weaponized against us. Like the people that are trying to provide, talk about the importance of mammograms, they're like, you're just trying to sell a mammogram. And that's not how this works. So I think that Well, I think what we're seeing is, social media misinformation and disinformation just going rampant. And people see breast cancer as a money-making machine, right? So mammograms have a very small amount of radiation. It's negligible. It's equivalent to flying cross country on a plane or 7 weeks of background radiation. Yes, too much radiation can cause cancer. We know that. But this is a negligible amount of radiation. And the benefit of mammography is that we are able to detect microcalcifications that you need from an X-ray that has radiation. The microcalcifications can be the first sign of breast cancer. So that small amount of radiation allows us to find breast cancer at the earliest, most treatable stage. Other modalities like ultrasound and MRI can't detect the microcalcifications that we're looking for, which is why a mammogram really plays an important role. Now, you're going to start seeing a lot of wellness influencers saying, oh, mammograms have radiation is bad, therefore mammograms are bad. And that is you can't jump from A to B to C, like from A to C without talking about everything in between. If the mammograms were the problem, we would be seeing older women just getting the increasing rates of breast cancer in older women. And that's not what the data is showing. The data is showing that we are seeing an increase in rise in young breast cancer, the highest in their 20s at 2.4% per year. These women have never had a mammogram. There is something going on in the environment. There is a widespread young breast cancer epidemic, but it's not the mammograms. And by spreading this misinformation, it scares people away from wanting to get a mammogram. And, and then they're trying to sell you an alternate screening modality that is not approved. I've seen thermograms, I've seen QT imaging, and all of that. It's just, excuse my language, it's just bullshit. Like, they're just preying on people's fear of getting breast cancer. First, they're going to try to scare you into not getting the screening test that they should be getting. Then they're going to talk you into joining their coaching group where you could prevent developing breast cancer, which is not true. And, and then you're not going to, it's just such a slippery slope, and it's infuriating. And it's really the reason I decided to put myself out on social media, because there are so many women that fall prey to this misinformation because it's sparkly, it's fancy, it's shocking because it's not true. But that shock value is what gets you, right? It's clickbait, and it's really dangerous. And there's usually an ulterior motive behind the person who's trying to scare you away from getting a mammogram. Usually they're going to try to sell you something else to either find your breast cancer or prevent you from getting breast cancer. That is not going to do either of those things. So for people that are worried about breast pain that they might feel during a mammogram, well, one, I will start off by saying that I think the media completely over-exaggerates the experience of a mammogram. I guess you both have had mammograms before. Would you say the experience was terrible or mild or moderate? Where would you
Mine's
say
coming
it
up in a
falls?
couple weeks, so
I've had a few now, and compared to a lot of the other screening things I've had to do, it wasn't that bad.
Exactly. So I would say, it's definitely uncomfortable. I would say each picture takes less than 15 seconds to acquire on each breast. The way to make it less painful would be to schedule it on ideally a few days after your period, when your breasts are the least tender. And you could also really consider adding, like taking an Advil an hour or two before your procedure to help minimize some of that pain and swelling. But I would say for the most part, I think it's mild, but it's tolerable. I haven't had now I've had stereotactic biopsies, I had all the things. And I don't think it's like you said, it's not the worst cancer screening tool we
absolutely.
have.
And we are not trying to gaslight you. Like I said, at this point, I've done all of them, and I definitely don't think that it's in my top 3 for most uncomfortable things I've had to do. So
I would have to say the PAP and the colposcopy is number 1.
Oh yeah,
I bet
for sure.
so. Yeah.
I mean, I've had a colonoscopy, which the prep is also not fun. So I mean, that's why I say it's definitely not in my top 2 at least.
It's like the bane of my existence. It keeps me up at night because it's just a constant. And then, like I said, if I stand up to it, then I just get bullied by the people as I work for the big pharma. And I'm like, that is not what I do.
I know we always tell people that. People always accuse them. Like, I freaking wish there was somebody who was paying me extra to do, like, where are these people? You know, I mean,
I wish I got paid per mammogram, per click, per, for every, like, no, that's just not how it works. I'm going to read whatever breast cancer screening you get that's interpreted by a breast radiologist. Also, I want to say that a breast radiologist, in order to, claim that a study is read by a breast radiologist, we go through 6 years, we go, med school for 4 years, 6 years of residence, 5 years of residency, 1 year of fellowship. We have to have all these federal certifications. And when these studies, the thermograms, the QT imaging, they're read, they're not interpreted by a breast radiologist. They're just interpreted by maybe a doctor who took an 8-hour course in this type of imaging. And that's not the same thing.
Absolutely.
That's a really good point. I feel like that specifically, I haven't heard that as much around when people are talking about those modalities. They're not knowing who's actually reading that imaging. Yeah.
Yeah. I've had so many patients come in, they had a negative thermogram or QT imaging, and they come in because they have a lump that's just getting bigger and it's breast cancer. And they're like, how? I just had a negative thermogram. And I was like, well, you just got suckered. And I hate it makes it that much worse. It makes it like, I'm sorry, someone pulled the wool over your eyes and they didn't have your best interest at heart.
Absolutely. Yeah.
It's heartbreaking that's happening. And it's happening so often. You're seeing it because it really is true. Everyone talks about like the big pharma stuff. Well, it's been around so long that big pharma's been around that honestly, there's a lot of rules on us that we can't do things like it would be illegal for you to be, shelling out mammograms left and right and reading them in certain ways so that would increase, what revenue that you got back from it, your income from it. And the same thing, I don't get paid anything for giving a vaccine. I lose money on giving for vaccines. Like it doesn't actually even come out even for me. It's because it's important to do. It's not because I'm trying to make big pharma the money. And so, we're not part of the insurance and big pharma industry. We're kind of these middleman people who are just trying to do right by our patients. And I hate for you that you've been in and you have to be in this online, arguments or sometimes, with these influencers or whoever that's you're just trying to actually spread information that's helping them.
It's really scary. And talk about self-referral. Like a lot of these people will, because they're not out of it's not covered by insurance. So they're going to recommend that you get this test and then they're going to read the test and they might recommend you need another test and they get paid every time you get the test. Like there's a big problem there as well.
So this has kind of been a little bit of a change, I think, for a lot of us since we trained originally with breast MRI being thrown into the recommendation. So when are you recommending a breast MRI for patients?
So I like to typically think there's basically 2 categories of patients that we typically recommend that have a breast MRI. So patients that are high risk, right? So we talked about that greater than 20% lifetime risk of breast cancer on whatever risk calculator you're using. Also patients that have a history of chest wall radiation or like for a lymphoma when they were a child. Known genetic mutations, women with dense breast tissue that want extra surveillance. And then there's more of the diagnostic setting. So someone that's been diagnosed with breast cancer and they want to know what stage it is or how extensive it is. Also neoadjuvant chemotherapy, seeing the response to treatment. Those are typically the diagnostic settings. Occasionally, if there's like something inconclusive on a mammogram and ultrasound, we might do an MRI, but I think that's the least reason to get an MRI.
So now I also believe that contrast mammography could be the screening future. And I think we've heard that that's another thing that you're passionate about as well. Tell us a little bit about how that's different from standard mammography and especially for that dense breast tissue.
Yeah, I personally would love to see contrast mammography done as a routine screening. I know I'm going to get some backlash for that because it does involve a contrast injection. So contrast mammography is like a mammogram and an MRI had a baby. It takes all the benefits of mammography, meaning that it can detect the microcalcifications, of early breast cancer, but it also has a contrast component. So a physiologic component. So the contrast, anything that's abnormal will enhance. So it will let you know if something is enhancing and if it has suspicious calcifications. And it's just a more sensitive and specific tool, especially in the setting of dense breast tissue. It really makes the dense breast tissue just disappear. It uses iodine-based contrast, which is different from MRI, which uses gadolinium-based or heavy metal-based contrast. And I know some people have an issue with the heavy metal in MRI. So that's one of the benefits of contrast mammography compared to MRI. It's also much more accessible. It's a lot cheaper. It's essentially just the cost of a mammogram plus the contrast dye. And it's a lot quicker. The whole study takes about 10 minutes as opposed to like 45 minutes of a standard breast MRI. Abbreviated breast MRI is quicker. It's kind of equivalent to abbreviated breast MRI. But again, you don't need to do this on a magnet, so on an MRI. So in place in the middle of nowhere where they may not have access to an MRI machine, it's a great test too. So I really think it's helpful, especially I would like to see it being used for breast cancer screening, especially in the intermediate or high risk population with dense breast tissue.
Awesome. Well, I'm sure we'll get there one day, hopefully. And one of the questions we get a lot, or
Yeah.
at least I do, is about breast implants and how that changes what or when you should screen. So does it change the recommendations to have breast implants?
It does not. So when you have implants and you come in for your mammogram, we do an extra view called implant displaced views. So they basically do regular views with the implants in, and then they essentially push back the implant and just kind of look at the anterior tissue. It's kind of interesting. I have one of the stories on my page, but and that allows us to see, around the breast implant. It also, but that's really the only thing. I would also say that sometimes having an implant makes breast tissue appear more dense because it's just kind of pushed up. So if you weren't dense before, you may be dense after an implant or deemed as dense. So you might want to consider adding an ultrasound or MRI. Also, some MRIs, if you have some implants, if you have a silicone implant, then you might need to add on an MRI. Oh, I forgot this one when we talked about MRI, but an MRI looking for implant integrity. So I can't remember the recommendation, but after it's placed, I think it's like 3 to 5 years after it's placed. And then some interval after that is when they look for silent breast cancer rupture with a silicone implant.
What about those who are going to do maybe like a breast lift or even like a fat transfer? I know those are topics of discussion in plastic surgery as well.
Yeah. So as someone who just had a breast lift, and I can relate to this. So it is going to make my breast look slightly different on a mammogram, but I was really considering doing fat transfer with my breast implant to make it more full. But I was honestly worried about the fat necrosis that would probably happen with the fat transfer that shows up on a mammogram. It's not a problem. It is like, it's truly not like fat necrosis is not a problem in itself, but it can be confusing in the beginning when fat necrosis is kind of calcifying. It can be confusing whether it's suspicious calcifications or if it's just fat necrosis. So, I could see the situation where a patient might need a biopsy because of the fat transfer. They start developing coarse calcifications. They might even feel a lump in that area where the fat essentially dies and calcifies, because not all the fat that they inject from a fat transfer will actually take. A lot of it dies off. So if they do too much at one time, then often we might see chunky fat necrosis in the breast. We see it a lot with patients that have had breast cancer. Especially if they've had radiation, then we often see fat necrosis. Like I said, fat necrosis itself is not a problem. It's the fact that it causes new calcifications in the breast that can be confusing and might warrant a biopsy to make sure it's not breast cancer.
Yeah, makes sense.
It's good history to know, and I guess my other question on that one would be, if somebody is high risk, is it, was it advantageous to maybe tell them maybe it wouldn't be a great idea to do the fat transfer or, these added things?
Well,
I guess that becomes another question, right?
I think that like a lot of times fat transfer serves its role. Like if you had breast cancer, you had a lumpectomy, you have some like actually a filling defect where that lumpectomy was, then I think fat transfer is very reasonable. I think in my case, it was completely cosmetic. I mean, I was getting something taken out, but the rest of it was cosmetic. I decided not to do the fat transfer. I could always go back and do a fat transfer. Right. That's, less of a procedure than the actual lift portion. But for someone who's just choosing it for cosmetic purposes versus a breast cancer indication, then I think they're two different things. And I think that the risks need to be weighed heavily. But I think, in breast cancer patients, it is a great tool, especially if you have like a little bit of volume loss, after surgery, that if they want to fill that in without an implant, then a fat transfer is very reasonable. And like I said, it's so common. We see it on a lot of patients. They might have they may have fat necrosis even if they don't have a fat transfer, just from the lumpectomy and radiation.
Yeah, absolutely. And I think a question that will probably answer will help put a lot of people's minds at ease is, okay, so your screening's abnormal. All right. And people are always afraid of like, what's going to come after that. And then sometimes that's the reason they don't get screening, just because they're worried about what comes after that. But say that happens. What is usually the next step people can expect if they have an abnormal screening?
Well, I want to start by saying, if you have an abnormal mammogram or you get called back from your mammogram, take a deep breath.
Yeah.
Okay. Because the numbers are in your favor, and I'll walk you through the numbers. Okay. So about 10% of women get called back from a mammogram. The number is higher if it's your first mammogram, and you have dense breast tissue, meaning that we don't have anything to compare it to. So we don't have, this is your baseline mammogram. So numbers are definitely higher. And you're more likely to have dense breast tissue. So for those two reasons, you're probably more likely to be called back, especially from your first mammogram. So like I said, 10% of women are called back from a mammogram. So 100 women come in for their mammogram, their screening mammogram. 10 of them, 90 of them will be told that everything's fine, come back in a year. Another 10% of them will be told that there's something abnormal, they need to come back. And something, what that could mean, something as benign as like we see a little probable cyst or we see definite breast cancer. You don't really know until you actually read the report and you see what words they're saying. But even then, you may not be able to tell. But when you come back, so 10 women come back, they get called back. 6 of them, of those 10 women, will be told that everything is normal. It was just a cyst. We'll see you in a year. 2 of them will be told that it's probably benign, that we want to follow you at 6-month intervals for essentially 2 years and prove that it's nothing to worry about. And then we bless you. When we say it's probably benign, we're saying it's a less than 2% chance of this actually being breast cancer. So it's not 0, but we follow these patients closely. I typically give these patients the opportunity to say, you know what, if you're uncomfortable with that, let's just biopsy it, because I'm okay with less than 2% chance of this being cancer. You might not.
Right.
And, if you're going to lose sleep over this thing for the next 6 months, we might as well put it to rest. Okay. So 2 of them are told it's probably benign of the 10 women. And then the other 2 of the 10 women are told that they need a biopsy. Okay. So of the biopsy recommendations we give, 80% of them are benign. Which sounds like crazy. Like it sounds crazy high to the amount of biopsies, but 20% of them are cancer. And it can be very hard to tell, just even morphology. When we look at this, we're giving it morphology and we're basing it off of how it's shaped, what it looks like, how big it is. So when we give a biopsy recommendation, it's also important to know if it's a BI-RADS 4 or BI-RADS 5. So BI-RADS stands for the Breast Imaging Reporting and Data System. It's a code that your radiologist will generate when you get your mammogram. So this is important. So it goes 0 through 6. So BI-RADS 0 means you're called back. You need more information. Okay. BI-RADS 1 and 2 are essentially negative or normal. BI-RADS 3 is probably benign. We talked about that. Less than 2% chance of being cancer. BI-RADS 4 is a very wide range of it being cancer. So it's anywhere between 2 to 95% of that being cancer. You can break it down into 4A, B, and C. Most radiologists don't. If you're going to give it but if it's very suspicious, they're going to give you a BI-RADS 5, which means highly suspicious for malignancy. If it comes back benign, we're not buying it. We recommend that you take it out because it looks like it should be cancer. So it has to make sense. So when we talk about 80% of the biopsies we do that are diagnosed end up being cancer, that's talking about BI-RADS 4. Because if you have a BI-RADS 5, the radiologist is essentially telling you, like, this is breast cancer until proven otherwise. We need to get you a team in place. I know it can be very scary to be in that, fall into that, like you need a biopsy, but the earlier we find your breast cancer, if this is breast cancer, the earlier we can find it, the better off you will be. You can have better chances of, a full survival, greater than 95% survival at, 20 years. These are great odds. So I would say the earlier we can find your breast cancer, the better. Early detection is the breast protection. And we're going to get through it. Like, this is why you're here. Like, thank God you came in when you did. And I really tried to emphasize it was only going to get worse. It wasn't going to get better. Like, ignorance is not bliss, especially when it comes to breast cancer. So I really just tried to refocus them, make them feel like we're going to help them get the team in place that they need to beat this. And it's going to be a hard few years, but you're going to get through it. And it's going to really change your perspective on life. I see many breast cancer thrivers who it puts their life into complete perspective. Like the before them was so different than the after them. And it's so much stronger and so much wiser and so much more perspective on life and what matters truly. I just want to mention that on my page and on my boob tube, which is my YouTube, I have every type of procedure highlighted. So if you need an ultrasound guided biopsy, stereotactic biopsy, MRI guided biopsy, it's all there under highlights. So that's really helpful. Also, having just gone through this process as a patient myself, I think it's really given me a lot of perspective, and I know how scary and unsettling this whole situation can be. But just like I said, knowing that you are taking care of this at its earliest stage should be reassuring and really empowering. So I wish you the best of luck.
Thank you so much again for joining us today, Dr. Roth. It's so much fun to talk to you. It really is. You're so knowledgeable. We want to encourage all of our listeners to go follow you at the Booby Docs on Instagram. Go listen to her podcast, especially for somebody, if is going through that really stressful, scary part of the biopsy with the what's next or the recent breast cancer diagnosis. It's really important to have that evidence-based, factual, that true expert guide you along that process. And of course, if you're a listener claiming CME credit for the episode, please look in our show notes for those instructions.
Yes. And for all of our listeners, thank you for tuning in. Please like, subscribe, follow all of us on socials, and let us know through our socials what you're interested in hearing about next.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Carrie Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Carrie Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.